So I've realized I'm not only the one standing between you and food, I am now also the one standing between you and the culmination of this meeting and our sojourns home. So I'm going to start off with an apology for both. I will try to keep this short and sweet, but there is a ton of info packed into this. First of all, I want to thank the AOCA for inviting me to come speak on this. Pain management is definitely a passion of mine, and especially broadening and advancing the horizons of it, and that's what we're trying to do. I do have some disclosures. I will be speaking on some of these companies today, or at least some of these products. However, everything is unbranded, and I'm honestly trying to speak on all of the products. So give everybody their fair share. Our learning objectives. I've given this talk a couple of times. I've expounded it and expanded it every single time. But what I always like to do is look backwards. Where have we been? Where are we currently, and then where do I see us broadening? So I'm going to do a brief review of some current interventional pain therapies, advancements in these current therapies we already have, and then hopefully some ideas of where I think we're going to go in the future. So for the longest time, this has been the status quo of pain. All of our conservative therapies, we have all of our over-the-counters, our regular medication management, physical therapy, throw in opioids there if you must. And then we started doing some interventional therapies. We started with some regional blocks, sympathetic blocks, ESIs, moved on to medial branch and facet blocks. This has been kind of what we consider bread and butter pain for a long, long time. So what are some advancements that we've made even in this? So recently there have been some articles showing best practices of radiofrequency ablation, but historically this came out in 1970. It was actually first utilized for trigeminal neuralgia. We've now since expanded the applications. We're doing spine nerves, we're doing other peripheral nerves. We've also expanded different techniques of doing this. We have heat or thermal, which is most commonly used, cooled, also pulsed radiofrequencies. We have multiple different techniques of being able to do this. The neat thing about this is it kind of preferentially destroys, if we want to say that, these A delta C fibers, which we know carry pain. What's difficult about this therapy, however, is that it's under constant scrutiny by our payers. So this landscape is continually changing. As of this year, radiofrequency ablation of the sacroiliac joint has been taken off nationwide of the payers. Down in my LCD, it's never been a thing, versus when I was in fellowship in Ohio, we could do it pretty routinely. So this is an ever-changing landscape, especially with some of our more peripheral nerves. Also, the repeatability and when we're able to prescribe this therapy for patients and have it paid for, especially in the cervical or lumbar spine, that's an ever-changing landscape too. So, moving on to some of our more advanced therapies, spinal cord stimulation. This is a therapy that's actually been around since 1960. Dr. Shealy placed the first electrodes in a patient's epidural space to alleviate end-of-life cancer pain. They were actually connected to an external cardiac pacemaker generator. I won't mention the patient passed away, I think about 3 to 5 days later, but that was other circumstances, but during that period, the patient was actually very much pain-free. In 1989, the first FDA clearance was given for spinal cord stimulation for pain, the treatment of chronic pain from the nerve damage in the trunk, arms, or legs. So we also have intrathecal therapy. In 1980, the first intrathecal pain pump came to market. Again, these were originally externalized. It was FDA approved in 1984, and it's when it was first used, originally mainly for terminal cancer pain. After this, it was branched out into non-cancer pain. Honestly, this is still probably one of the best therapies we have for refractory bone pain secondary to metastatic cancer. Dr. Lisa Stearns did some amazing research with intrathecal therapy showing that we're actually improving not only these patients' quality of life, but their length of life, their longevity after cancer diagnoses when we get their pain well controlled with these intrathecal therapies. So how have these things changed? This is where we've been, and where is the status quo? How has the landscape been modified in the last couple of years? So when we talk about spinal cord stimulation, One of the first big studies that came to market came back in 2015 with high-frequency stimulation. Dr. Krappel published the first level 1 randomized controlled trial comparing traditional, what we call tonic-based spinal cord stimulation against this high-frequency or non-paresthesia-based stimulation. I've got the numbers up here of the traditional SCS versus the high-frequency and the results there. The traditional SCS in this study actually did very well, 55% and 43%. Sadly, that was what we had at the time. One of my mentors, Dr. Nagy McHale, always termed it the 50-50 club. 50% of patients will respond about 50% of the time. And that's where traditional tonic stim had been for many, many years. And this was the first study that came out and said, wait, we can do much better than that. Let's blow it out of the water. With high frequency, we don't truly know the mechanism of action yet, and it's kind of destroyed some of the mechanisms that we thought we knew in other spinal cord stimulation, but we think it modulates the spinal cord just a little bit and promotes pain relief that way. This data that I have published, or I have up here, I think was the 3-month data, but this has been sustained out to 24 or to 12, and then also out to 24. They had a very, very good cohort they were able to follow this whole time. When we start looking at very specific focal types of pain, Dr. Deere came forward in 2017 promoting dorsal root ganglion stimulation. So this picture up here, instead of having 2 epidural electrodes, we actually have 2 smaller dorsal root ganglion electrodes that are actually exiting that neural foramen, lying over the DRG to provide stimulation. This was the ACCURATE trial. Again, this was a head-to-head study between traditional SCS and DRG stimulation, and proved that DRG was superior usually for focal pain. So this is more on label for CRPS or causalgia, usually of the lower limbs. It is used in the cervical spine in some patients. However, that is actually an FDA off-label use. Again, in 2018, Dr. Deere published the BURST trial. This was a crossover trial between tonic stimulation and a new proprietary BURST waveform. The thought behind this is that this was going to be a more physiologic waveform. They studied it at 12 and 24 weeks with an intention to treat analysis. It showed that for these patients, this BURST waveform was superior to traditional tonic SCS stimulation. So this study was one of the landmark papers to look into the actual waveform itself. We had always looked into either tonic or high frequency, but we never actually looked at the physiological waveform, what it was beginning to do in the spine. So each one of these papers I've presented has been kind of landmark pivotal in the way we've thought about spinal cord stimulation. And that has done nothing but continue. In 2021, Dr. Fishman came out with a differential targeted multiplex stimulation. This is kind of a cascading type of stimulation therapy that again was compared to traditional tonic spinal cord stimulation for patients with chronic low back and leg pain. And at 3 months, again, we're seeing much better results than we had in the past. 80% in the DTM group compared with, again, the 50-50 in the traditional SCS. The responder rate in this case was considered percentage of patients with greater than 50% relief. This is 3-month data, but they show that it was sustained out to 6 and 12 months. This was based on some research actually done by Dr. Vallejo and in a rat model based on the glial cells and glial cell modulation by this particular waveform. Again, looking at the waveform, Dr. McHale published a paper in 2020 on the first study on closed loop stimulation. So this is actually something that sounds very big and fancy, but especially as anesthesiologists, something we're all very familiar with. When we talk about medicines, we always have a therapeutic window, correct? We know what dose produces a response and what dose starts to become detrimental to the patient. Well, in spinal cord stimulation, we've never had that. We've just thrown energy at the spinal cord and see what it does. This was the first time we went back and looked, well, what are we actually changing when we apply that energy? So this is based on a therapy where we apply a stimulation at one electrode and we read the output at another electrode on the same lead. So we effectively close the loop, and then we can modify that next signal output to keep the spine, or keep the energy delivered to the spine within that therapeutic window. So this again was a double-blind level 1 randomized control trial based on, like I said, these evoked compound action potentials. So each one of these patients was implanted, their specific ECAP was captured, measured, programmed into the device, and the device was told to stay within that stimulation window. This has been a long time coming for those of us that have been looking forward to it. I was introduced to this therapy in fellowship because I worked with Dr. McHale, and it actually just recently came to market within this last year in a very, very limited rollout fashion. So we're super excited to have this. So everything I've talked about, this spinal cord stimulation, has all been for very, very specific diagnoses. If we're going to talk about how are we going to get these therapies implanted in patients, we're also going to have to talk about what diagnoses, one, payers like and what diagnoses they're on label for. So traditionally, we've always used the failed back surgery syndrome. Patients who have already had back surgery still have continued refractory pain. CRPS, both 1 and 2, are both well-accepted diagnoses for all of the spinal cord stimulation. Recently, there's been a little bit more intractable low back and leg pain, but most of these patients always had to have surgery or an injury or something else first. Eventually, we got some of these therapies expanded to treat chronic pain in the trunk or limbs, but it's always been, again, they had to have surgery first. So a dear colleague of mine, Dr. Peterson, came forward in 2021 and proved something that all of us kind of knew anecdotally, that when we implanted one of these devices in patients with painful diabetic neuropathy, their neuropathy got better. Their back pain was better, great, that was what we put it in for, but their feet got better, and we didn't know why, but we all knew it was there, but we could never put it in patients that only had diabetic neuropathy. We had to turn these subset of patients away. So Dr. Peterson went for this trial with just painful diabetic neuropathy. Again, they compared high-frequency 10 kilohertz spinal cord stimulation to conventional medical management. And at baseline, their VAS scores were about the same, but in the high-frequency spinal cord stimulation cohort, it dropped considerably compared to the conventional medical management actually getting a little bit worse over time. So because of this, we actually got a new FDA on-label indication for painful diabetic neuropathy thanks to this study. Again, I think I've got my 6-month data here. This has now been since carried out to 12, and then just recently at the beginning of this month it came out to 24 months, and I think I have that in a little bit later. What was neat in this, I was actually involved in this trial the very, very beginning of this study when I was in fellowship. And one thing we postulated even back then was, as we changed the sympathetic nervous system of these patients, are they going to start to regain sensory function? So we did some pilot studies when I was a fellow, and it's actually just now come to fruition. That paper that was published at the beginning of the month shows that about 65% of these patients at 24 months had notable return of sensory function in their lower extremities. This is now the first time we have actually a disease-modifying therapy in interventional pain. So I think that's really quite cool. With this research, it is now recommended both by the American Diabetes Association as well as the American Association of Clinical Endocrinology. It was actually included in their 2022 diabetic guidelines. So our endocrinology colleagues are beginning to see that these therapies can impact their patients. With the 12-month data, they published a white paper showing that these patients also had a lowering of their BMI and a lowering of their improvement of their hemoglobin A1C. So with chicken or the egg thing, which are we fixing? Are we making these patients more comfortable so they're becoming more active and therefore losing weight, improving their glucose control, or are we doing something a little more physiologically in the way they process glucose? We're not sure yet, but it is pretty cool. Oh, I do have the 24-month stuff in here. I couldn't remember if I had thrown it in or not because it was so new. So yes, these patients continued that 80% reduction in their pain to baseline. One thing I like in pain right now, we're having a huge push to also improve functionality scores and quality of life. Pain itself is so subjective. It's hard to read. It's hard to truly get objective data on that. So we're showing improvements not only in quality of life, but also improvements in sleep, as well as improvements in function. So that's a big goal of ours. So 90% of patients reported greater than 50% pain relief. That was the cutoff. They all improved showed significant improvements in quality of life and in sleep. As I stated, 65% developed clinically meaningful neurological improvement. Of note, this is a patient population that we historically, as pain physicians, may have shied away from. High hemoglobin A1Cs lead to infection risks, right? At the 12 and 24 month data, that was something they were following. They actually showed no increased infection risk in any of these patients. And I, for one, can tell you, fellows were doing some of the implants. So yeah, there's your surgical technique there were not always the best. But in total, even at 24 months out of, I believe they had 161 patients at this point, something like that, there were only 5 explants due to infection risk. So overall, we showed there was no higher risk in these patients with a much higher cutoff hemoglobin A1C than most of us were traditionally implanting. The expounding our parameters didn't stop there. In 2022, the FDA expanded the use of high-frequency stimulation for the management of intractable back pain when the patient's no longer a candidate for back surgery or when back surgery hasn't been performed previously. So again, we're widening this breadth of the pool of patients we can offer amazing therapies to. This indication was based on a meta-analysis study that was a bunch of pooled data by Dr. Aoca Gs that showed the average back pain for these patients was decreased by 70%. Also, like I said, we're trying to show improvements in our patients' functionality. Their ODI, or their disability index, was decreased on average 15%. We also are trying to, in lining with the opioid epidemic, decrease the use of opioids overall. In this particular meta-analysis, overall the opioid use was halved. So could this help prevent unnecessary back surgeries in the future? That's my hope. If you talk with any good spine surgeon, they're going to tell you, I can treat leg pain really well. If I need to do a decompression surgery, the statistics say that I will get rid of that radiculopathy. But when we talk about just straight axial back pain, the stats just aren't there. The data's not there to support it. So a lot of patients were going under the knife with a very risky opportunity of getting pain relief or not. So this is hopefully a therapy that will step in and kind of fill that gap. Also, as you know, spinal cord stimulators, especially when we're able to do percutaneous leads, can be easily removed. So if something detrimental happens to the patient, in the long run, they do need a further decompression surgery. We've not burnt any bridges for them, so to speak. That can be modified in the end. So where do I see spinal cord stimulation therapy continuing to go? As I've mentioned, we're now looking more at the waveforms. There's a ton of research with a ton of different companies looking at how these waveforms are actually modulating the spinal cord. What are we actually doing? We really don't know right now. Again, we're throwing energy at things and see what it does. There will always be a discussion on your primary cell battery versus your rechargeable systems. They each have their pros and cons. I use both somewhat interchangeably. If I have a patient with memory issues that's not going to be able to remember to charge, I'm going to put a primary cell in them. I'm going to take that burden off of them. But if I have a very tech savvy that wants all the bells and whistles, I might put a rechargeable system in them because it does broaden their parameters a little bit more of what I can offer them. In my world, MRI conditionality is a big deal. We are now putting these therapies, these are no longer therapies of last resort. We are putting these therapies in much, much, much younger patients and patients with all sorts of diagnoses that will need MRIs in the future. And condemning a patient to only being able to receive CTs as advanced imaging for the rest of their life, the overall radiation exposure is huge. So MRI conditionality, most systems have an MRI conditional component, but that's something to look into. What parameters does the stim itself have to be in to meet those MRI conditional criteria? That does vary from company to company. We are now looking at some artificial intelligence-based platforms. So we have all of this data out there of how patients do best with spinal cord stimulation, what waveform, what settings, what programming. So these AI platforms can actually help guide patients down this pathway, usually a little bit quicker and with a little bit better results. Instead of having to wait, come see me in my office, coordinate with the rep, they've gone through this period where they don't get therapy or they get inadequate therapy because they're waiting pretty much. The AI platform can help guide them through it. One of my dear friends alluded it to in the analogy, and somebody brought up waiting in line on the phone for an airplane. When was the last time any of us actually called to make an airplane reservation? We all get online and just do it, right? Unless you have a problem. then you immediately want somebody to talk to you. This is where that AI platform kind of steps in. It is that app on your phone, made my plane ticket, no issues, okay, I'm good, versus, oh, every flight is delayed, I want to speak to someone. This is kind of to bridge that gap. We also have some newer therapies now that, just like our pacemakers, just like some of the CPAP machines, that are actually uploading to the cloud every single night. So I can see how my patients are doing. I can see, are they utilizing their therapy? I can see, oh wait, Mr. Smith hasn't charged in 2 weeks, something's going on. I need to get him in and maybe do a re-education on the best way for him to utilize this therapy. So we're advancing really on all fronts. With that, as our systems continue to decrease in size, it's also brought up expanding our boundaries. These no longer only have to be placed in the spine. We are doing a lot more peripheral nerve stimulation right now. I have some of the more common approaches up there right now. Again, I have my little disclaimer at the end. This is a changing coding landscape. Some new codes came out this last year for peripheral nerve stimulation. They will probably continue to be changed a little bit if you listen to your RUC colleagues. But this is, again, a therapy that we can now offer to patients that we couldn't in the past. Some of these options were options before, of being able to treat shoulder pain, of being able to treat ankle pain, or especially with patients that didn't want or couldn't have any therapies placed into their spine. So I briefly mentioned intrathecal therapy earlier. I'm going to step back to that. Intrathecal therapy has been around for a long time, but we're still having some newer research on the best way to utilize this therapy. The old theory was high-dose monotherapy. This led to the formulation of granulomas at the tip of the catheter. We also had a large population that probably had induced opioid hyperalgesia. So these patients had to wean, we had to turn pumps on and off, we had to supplement them with orals. It was just this kind of horrible cycle. So some newer research is actually pushing towards microdosing. This is based on 2 different studies, one by Hamza, one by Greider from 2015 and 2016. They made their patients wean their opioids prior to implantation, one prior to trial and implantation, one just a partial wean, one to off. Obviously, these were not cancer patients. These were chronic non-cancer pain therapies, but each showed an improvement in functional status when we got those morphine dosages quite low with 0 oral supplementation. This is technically off-label, but there are plenty of practitioners who also use admixture therapies with very, very good results. Again, this is no longer a therapy of last resort. We're putting these in patients that have other options but desire a better way to be treated. So, now the fun stuff. Where do I think pain is going? I've spoken a lot on therapies that we've utilized a lot in the past, but our horizons are getting broadened. Really, when we talk about pain, when we talk about just about any condition in general, there's much more of a push for minimally invasive therapies, right? In my world, specifically, we're now seeing the ability to not only treat, but halt some of the causations of pain instead of merely palliating them or chasing the pain generators. So I'm going to back up and talk anatomy just for a minute. When we talk about lumbar spinal stenosis, it is the most common spine disorder in older patients. Pretty much every single patient that walks in my office, I can give them this diagnosis without even looking at their MRI. Usually I can see it off their gait or even just their age. This becomes such a common diagnosis. We see this every single day. The original theory was kind of based on this spinal degenerative cascade. So as the discs begin to dry out and shrink in height, we have a little more of a curve tilted forward that translates the weight back posteriorly, and the facet joints, the interspinous ligaments, those were never designed to carry the weight. The disc has always been what's designed to carry the majority of the weight. That leads to this central and lateral and foraminal recess narrowing. This combination of things is what causes that neurogenic claudication signs and symptoms that we see. So the little old patient that comes in on a walker, or the patient, one of my questions I literally always ask my patients, all right, we're gonna go get a gallon of milk at Walmart. Everybody knows where a gallon of milk at Walmart is. It's always way in the back corner, right? How are we, there are no riding carts, you can't get on the motorized. Are we gonna make it to the gallon of milk and back? Nope, not even gonna try. That's this patient. Okay, what if I get you a cart and you can kind of like lean over on that cart? Can I get you a little further? Can I get you closer to that gallon of milk? Can we make it then? Sometimes. That helps me know what sort of positioning brings them comfort. That's one of my big buzzwords. So I talked earlier about the disc being the first thing to dry out. So we have some newer products now where we can attempt to supplement this disc. The goal is to rehydrate, reestablish the normal cushioning function of the disc itself. This should be carrying about 60% of the weight of the spine, but like I said, as it dries out, that will decrease. Multiple studies have been performed on various materials. Currently, there's only one commercialized product that supplies cadaveric nucleus pulposus material into the disc via a needle, so a discogram that all of us have done. However, my one caveat here, the original studies that was done on this product, that is actually not the product that is out on the market currently due to some changes done by the FDA. However, this I think is a field that is going to explode. This is part of that regenerative medicine field, and I see this doing nothing but getting bigger. So if we're transitioning back to the posterior column, our martifidi muscle is one of the first things that starts to try and carry the load as that disc begins to dry out. These are the small interspinous muscles that connect not only single segments but multiple segments. And specifically, when we start to actually have axial back pain, this muscle contracts, and I don't care how much physical therapy or how much postural therapy you try to do, you cannot override the pain signal to get this muscle to relax. It is actually a protective mechanism in our spine. So what we see over time with patients, and if you go and look at some of your MRIs, which I encourage everyone to really become facile at reading your own MRIs, you start to see multifidi muscle atrophy. You start to see fatty infiltrates into this muscle. It is no longer doing the job it was designed to do. It has lost stabilization capabilities for the spine. So this was a company that came in and said, hey, what can we do about this? This is technically a peripheral nerve stimulator. That's the code that it goes under. But we're actually reinnervating and stimulating those multifidi muscles. And this is kind of like a little physical therapy program. They run it for 30 minutes twice a day. At their 3-year data, 50% of patients had, 77% of patients had a greater than 50% reduction in back pain, and 67% reported resolution of their back pain, so complete therapy. They also, again, in trying to prove functionality, decreased their disability index pretty profoundly. Again, this is one that's a little bit difficult by the payer population right now. It's a great therapy, just somewhat limited in its use because you can't always get it covered. When we talk about the vertebral body itself, we know that there are some pain generators there as well. Specifically, the basivertebral nerve is what innervates that true vertebral body. So what have we been able to do about this? We know as those discs dry out and they dehydrate, they start to leak inflammatory mediators. We see that, and we see the reactive changes in the bone in the form of Modic changes, who is actually named after a radiologist at the Cleveland Clinic. But these inflammatory changes that we see, we start to know that that basivertebral nerve is most likely implicated in their axial low back pain. So this is actually a radiofrequency technique entering through the pedicle where we're going in and we're actually ablating that basivertebral nerve. So again, from baseline to 24 months, these patients had a very good reduction in their VAS as well as a reduction in their ODI scores. So 31% of patients were also completely pain-free at 24 months. So it's a therapy that works and is showing long-term promise as well. They recently have some data out to 5 years. Again, my caveat with this, it's a great therapy, not fully accepted by our payers as of yet. Obviously, vertebroplasty, kyphoplasty, this has been a therapy we've had around for a while. However, we have some newer techniques for this as well. We've known that returning that compression fracture back to at least somewhat of its previous height, or more specifically, actually leveling out the way that end plate carries the weight. That is probably what's most important in preventing further subsequent fractures and adjacent level fractures. So there are some various products now to not only try and lift that back up, but also, like I said, level out that end plate weight to prevent subsequent fractures. I kind of alluded to this earlier. These are your neurogenic claudication patients. So these are we actually call it in my world the shopping cart sign or the walker sign. They're patients who, when they are forced to stand up straight and walk straight, they have traditional low back, leg pain. They tell you, my legs get heavy and weak. I have to stand and bend over a little bit, or I just need a few seconds of relief. And these are patients that get profound relief in flexion. So if they're able to sit down, even just for a few seconds, the pain goes away. It's very important to differentiate this from true vascular claudication. That's a very different subject, but this is truly neurogenic claudication. The other thing that I've seen that I didn't appreciate until more recently, these patients also complain that they wake up in the middle of the night with leg pain and heavy legs even in the middle of the night. And so when you ask them, well, what position are you sleeping in? Most of them are sleeping flat on their backs. Well, again, that puts them into extension. So it's the same therapy, or it's the same positioning, you just have a loss of gravity actually forcing it down. So it takes a little bit longer for symptoms to start there. So what are some things we can do about that? We do have the ability to go in and do a minimally invasive lumbar decompression. So what we're doing is we're actually trying to take out some of that ligamentum flavum. If I go back to my MRI, way back here, in this little triangle, in that MRI picture, you see that kind of weird black shaped U right behind the spinous process. That is actually pretty substantial ligamentum flavum. You can actually measure that on MRI, and that's one of the things that's putting pressure on where that spinal cord lives. This particular patient has a large component of what I would call central canal stenosis, a little bit less lateral recess and neoforamen at this slice, at least. It's one of those things you've got to evaluate in multiple slices. So what we can do is go in there, and we've got this little ice cream scoop type thing. We can go in and actually scoop out some of that ligament. There are two different theories on this. How much of that ligament are we actually removing versus how much of it are we just scarring down and getting it to scar back against the lamina? Either one, it works. The patients get good relief of neurogenic claudication signs and symptoms if they truly have a component of central recess. Recently, a new study has come out that has shown that the safety profile of this particular product is exactly the same as an epidural. So on a couple hundred patients, they showed no other risk factors that we wouldn't have with a normal epidural. Again, coverage for this can be a little bit difficult with some of the payers. It's not fully well accepted, although we're working to try and change that. So, other things that we can do. Interspinous spacers. So I mentioned that these patients have pain in extension, right? When they're upright. Well, what if we put them in just a little bit of flexion, or at least prevent them from extending? So what these devices do is they literally go in there, wedge between those spinous processes, and it is considered an extension blocker. You never want to actually put somebody into flexion, but you want to prevent them from being able to extend. This is a very minimally invasive approach. It's a posterior approach. The incision ends up being about as big as my thumb. One downside of these, over time you can begin to have some subsidence because these are not actually fixated to the spine. They are somewhat just wedged in there, but they do work well for patients who have no other option of ways to indirectly decompress that area. Kind of the next step up, we talked about that there's no fixation of those devices. These devices that I have up here are all different ways to actually fixate that spine. So again, this is going to be a minimally invasive way to provide stabilization to that lumbar spine. With all of these devices, you're going to get a component of indirect decompression. The way I do it, I actually don't want to wedge any of these devices in. I want to decompress them as I put them on the table. So most of these I do with a Wilson frame. I'm taking fluoro pictures before I've ever prepped and draped. And I want to reduce that segment or open that segment up via positioning before I ever put the device in. I don't want to wedge one of these things in. These are well accepted both by our neurosurgical colleagues, our orthosurgery colleagues, and ourselves. Some of my colleagues actually use these as a posterior backup to an anterior 360. There are some really neat things that are doing single incision 360s just with a lateral approach. So, and getting these patients actually to go home the same day. I'm not doing any of those, but it is a really, really cool therapy. So when we start talking about data to support this, I presented some of this during the SNAP session, but this is based on one of those devices that I talked about. This one's is actually a novel device that has a lateral approach to a posterior fusion. And the first part of this study, with 69 levels in 43 patients, they showed about a 93% fusion rate at roughly 459 days, so just a little over a year, evaluated by 3 independent radiologists. So we're showing that not only are these devices doing a very good job of indirect decompression, we're also showing that we are stabilizing that level with these fusions. This last summer, most recently in July, I actually had the opportunity to present some of my data based on about 202 implants, 191 patients. This was compiled by 8 different interventional pain physicians, showing that this device is very, very safe and very, very efficacious in our hands. It was done only by interventional pain physicians, none of our surgical colleagues. There were 2 adverse events in that retrospective study, but they were unrelated to the device or the procedure. And yes, I have to say, sadly, one of my colleagues in the paper put due to anesthesia. But these patients showed, our follow-up data was still a little bit limited. Average was about 3 to 4 months, showed about a 50% pain reduction score. I expect that to do nothing but continue to get better, because at 3 to 4 months, these devices are not fused in yet, so they still have some component of micromotion that will continue to progress. The REFINE study was a different study based on a very similar device. This is actually a posterior approach. Again, this was done with interventional pain physicians, though the chief investigator on this was a dear friend of mine who is a neurosurgeon, so he's very much in support of this. This was a prospective trial. Again, this is 3-month data. They just posted a white paper with their 6-month data that showed continuation of their same numbers pretty much. So this was a single-arm, multi-study, open label, but prospective trial with this particular device. Again, this is a posterior approach, so a little bit different, but very, very similar results. Again, they showed 82% of patients reported improvement, though they don't quote a number in this 3-month data, and 65% of patients improved clinically meaningful improvements, pain, function, which is what we want to show. They had 1 adverse event, but no, again, not device related and no long-term complications. So this is a pathology that is near and dear to my heart, because I think this is one that we miss a ton. I think this is one of the most underdiagnosed diagnoses in the world of pain management, sacroiliac joint dysfunction. So how many patients come in and say, the pain is right there, I can put my finger on it? These are the patients you need to be evaluating for sacroiliac joint dysfunction. Patients that I have a very, very high index of suspicion in, any of my postpartum patients, they come in with kind of acute SI dysfunction, and also if they've had lumbar spine surgery. So the SI joint is a joint. It is designed to move, but when we look at it, it's only designed to move about 1 to 2 degrees. However, if you fuse L4-5, you translate about 40% more motion down into those SI joints. If you fuse 4-5 and 5S1, that motion increases by about 150%. So these patients, think about that 3 to 5 years later, these patients, those joints were never designed to move that much. They end up with a substantial amount of pain. Their back surgery was a success. Their leg pain's gone. The back pain they actually went in with is gone, but they go, this is new, it's horrible, it's excruciating. It is also a little bit of a red herring. It can radiate to the buttock, the posterior lateral thigh, some into the groin. I've had some go to the lateral side of the calf. It can go a little bit everywhere depending on how it lies. Very, very common, very, very missed, and I actually see a ton of this. Things that are red flags for me. I ask patients how it is getting up from a chair. That is one of those motions that makes that SI joint move preferentially. Getting out of a car. What leg do you start to go upstairs with? These patients will never go upstairs first, preferentially at least, with their affected leg. They'll be like, yeah, I always step up with my left, I never step up with my right. So those are some little buzzwords that I've kind of picked up along the way. So what can we do about that? SI joint injections have always worked, but what if your patient becomes steroid refractive? Then what? As I mentioned earlier, sacroiliac joint radiofrequency ablation has been taken off of the payer's index completely as of this year, so that's no longer an option. And the data on that was somewhat mixed. It was about the 50-50 club as well. So we can actually go in there and stabilize it. Historically, the open approach for this has been a lateral done by our neuro and ortho colleagues. The M&M with that has been mixed at best. There's a much increased risk of bleeding, nerve damage because of the S1 and S2 foramen, as well as a significant amount of muscle retraction. On top of that, the original dowels that were designed for this were actually triangular shaped, and they didn't do a ton of drilling. You actually wedged those in, so there were a significant amount of sacral insufficiency fractures. But that has actually been the standard of care for these patients for many, many years. We are now looking at more minimally invasive options. I've got a couple of the options here. We still have some better lateral approaches now. We have some posterior lateral approaches, but then we also have some posterior approaches. There is some early data to support that the posterior approaches have just as robust stabilization as any of the lateral. It's a little early to tell, but the early stuff does show that it looks like they do as effective of a job. And then so it just depends on what technique you want to pick and what your safety and experiences are with each one of these devices. This, I again presented some of this earlier, and I was hoping to be able to present some other data, but I didn't get it in time. This was a 6-month, now followed up to 12, with one of the posterior bone graft allografts, and how these patients did in comparison with that standard of care that we talked about. So the interim results on the first 69 patients at 3 months showed a great reduction in VAS as well as a marked improvement in their functionality. There were 3 adverse events noted in this study, all unrelated to the device, but when I mentioned the fact that there were 17 in the standard of care study with a comparable amount of patients, that just shows that this device may be somewhat safer. This summer, there was some 12-month data posted on this, and they actually went back and pulled some of the other data that was very, very interesting, including length of anesthesia time, blood loss, very important in my world, exposure to radiation or fluoroscopy time. All of these things were decreased, excuse me, let me not misspeak on that, decreased with the posterior approach compared to the old traditional lateral approach. Again, this is a spot where the coding landscape is very, very interesting. This posterior code right now is technically a T code. It is under investigation. It will be a Cat 1 code at the beginning of the year. Again, it'll probably only be covered by Medicare for a short amount of time. Hopefully the commercials will go back and pick it back up again. I'm going to back up for a sec. The 27279 code, which has been our SI Fusion code, is getting reworded. There will no longer be, well, supposedly, this is what they're saying, there will no longer be directionality in it, so it can be a lateral or a posterior approach, but the goal is that you want to actually transfix the joint. So you have to have something transfixing from the ilium to the sacrum to count for that 27279 code, which has been the most commonly one used as of right now. So, like I said, it was a ton of information, but again, where do I see pain management going? I see overall advancements in medicine. I see advancements in our techniques, but this is also being driven not only by research and better outcomes, but by our patients. Our patients are requesting better and better care. They don't want that huge big spine surgery where they're going to be laid up with 2 to 4 months to 6 months of recovery. They want to get back out and doing what they want to do. They want to return to their quality of life. So to me, I love this graft because the more futures we can change, the more futures we can alter. That's where I want to go. That's where I want to be. That's why it's so exciting to be kind of on the forefront of this and continuing to push everything forward. So with that, I'll take any questions. And whoever brought up having all your references on a QR code, I am so doing that from now on. Because yeah, 3 slides of references is way too much.
So definitely thank you for your talk, but I also want to thank you because we had to do some shuffling around and you actually extended your lecture for us to meet the CME needs, and so we're very grateful for that. I want to open the floor up for any questions. We have a hand in the back there. Perfect.
Question about the interspinous spacer. Um, Looking at it, in my perspective, when you would put the spacer in, doesn't that decrease the space in the space above and the space below that because the spinous processes are moving upwards and downwards into those respective spaces, or doesn't it not impinge on increasing spinal stenosis in the space above and below?
In theory, it should, right? So this is based on some very historical data done by a product that's no longer out on the market. But when they did their cadaveric studies, which were the product itself was very, very similar to one I presented on. It was just a very different approach that was a little difficult. So that's why it's no longer out. Nobody uses it. But they did do some very good cadaveric data that showed that no, while we're able to indirectly decompress that area, we're not worsening stenosis above or below. But no, it's a really good question because yes, in theory it should, right?
A second question on the SI joint dysfunction, you skipped over, or maybe it's not even in practice anymore, radio frequency ablation. I dabbled in pain management when I came out. I'm not fellowship trained, but as I, you know, did some learning and training, I started doing the radio frequency ablation of the SI joint with the Simplicity probe. And in my very inexperienced hands, I had very good results of that, along with RF of the L5 facet separate ablation. Is that fallen out of favor? Or are you jumping right to the surgical techniques?
It's fallen out of favor in various aspects across the U.S. depending on your LCD. Up until recently, it was covered in some, but actually, as of January 1, it is no longer covered by any LCD in the U.S. So that's part of the reason it's fallen out of favor. The research on that, and we actually had a great discussion on this at one of our pain meetings. The research on that has been very mixed. Dr. Lee did a great meta-analysis review of RFA of the SI joint. Cooled or anything that gives you a bigger lesion does show better results than just thermal. Bipolar and skip lesioning can get you better results that way as well. But yes, you're 100% right. You have to make sure you get the dorsal root of 5 as well to truly get the innervation of that SI joint. The other thing is what was always missed when we did SI joint radiofrequency ablation is the anterior construct of that joint. It is innervated both from the posterior as well as the anterior aspect, and so we were never getting those anterior fibers.
Back to the interspinous devices. Part of the problem is L5S1. With Superion, you couldn't put it in, or you weren't supposed to put it in at the L5S1. With the newer devices, are they still recommending you do not apply it at the L5S1 level? And has anybody looked at the possibility of putting a nail into the S1 level to support for the device?
Yes to both. So the newer device, yes, exactly. The original interspinous devices or spacers were not designed for the L5S1. Because as y'all know, S1 doesn't have enough of a nubbin to set anything on. The newer products and the actual fixation devices have rectified that. A couple of the companies have a different implant to be able to use at L5S1 with differently shaped and oriented teeth to be able to grab into that posterior aspect of the sacrum. There has been some talk and some research looking at ways we could expand that S1 nubbin. Some people, I don't know if anybody's familiar with Dr. Doug Beal in Oklahoma City. He will throw some bone cement there to try and augment it. The hard part is there's so much variation in the depth of people's sacrums at that S1 segment that if we poke through it, you're at very high risk of actually a dural tear. Less so damage to the nerve roots because everything's kind of spread out at that point, but you're very likely to potentially interact with the thecal sac, and so not a territory I personally want to get into. They have looked into it, but I think because these devices have now come out with specifically 5.1 products that we've effectively rectified that.
Anyone else in the audience? Okay, I have a couple of questions. Mine are not going to be as intelligent as their questions, as I'm just a cardiac guy. But I was hoping maybe you could pontificate a little bit on. I've noticed in the ICUs we're starting to see a lot of bleed in from ER doctors and imaging. We're starting to see some cardiology taking on structural heart imaging. I know in the pain space there are a lot of people that are not necessarily anesthesia trained, PM&R and other specialties getting into pain management. Could you just talk a little bit about osteopathy, anesthesiology, what sets you up to be, I guess, the best in that space, and just talk a little bit about filling the needs of pain patients and whether this is a good thing or a bad thing?
Ooh, that's a really good question. I do. I feel like I'm in a very, very special, kind of specific role just because of my background. You're 100% right. The landscape of medicine is changing. The landscape of pain is changing. We're becoming a very multi-specialty demographic. Our pain meetings are now not only, it historically has been very much anesthesia-based, but it's now, I have neurosurgery colleagues coming to my pain meetings. I have orthospine colleagues coming to my pain meetings. Interventional radiology that I mentioned, physical medicine and rehab. We have a very broad scope coming. Where I feel like I step in, and the fact of having both an osteopathy background as well as an anesthesia background, I feel like I understand the structure and the function of the way things are meant to work much better than some of my other colleagues just based on my osteopathy training and principles. From the anesthesia standpoint, it makes it a lot easier for me to surgically prepare a patient for surgery because I know the parameters that they will have to undergo to go through an anesthetic. So I think I come from a very kind of mixed background that does nothing but help me. The big part that I feel like we're missing in pain actually goes back to my osteopathic principles completely. One thing, the way our system is set up, is we're not allowed to approach pain in a whole body view, correct? Pain is not one symptom. It is not low back pain. It is, how does it impact their work? How does it impact their family? How does it impact their activities of daily living? We aren't always at luxury to be able to approach those things. How do I get them? I always tell my patients, I said, I actually don't care what your pain score is. My MAs know. They don't come and tell me that. I really don't care. Your pain score of a 7 and my pain score of 7 are two very, very, very different things. But one thing I ask my patients at their first visit, and then I follow it up later after we've completed some sort of therapy. What can you not do today that you want to be able to do in the future? I make them be realistic. We're not going to go to the moon. But it's walk down the aisle at my daughter's wedding, or be able to bend over and pick up my grandkids and play with them for more than 5 minutes before my back is excruciating. So remembering to step back and not view the patient as low back pain, but to view the patient as a whole person and how it affects everything in their life and how it affects their family members, that I think is a point that we cannot forget and cannot overlook.
Well, if there's no more questions, I can't think of a stronger way to end than that. That was perfect, so thank you. If we can give her one more round of applause, please. Yep.